Hi, I'm Dr. Mila Brujic, and I'm joined by Dr. Cecelia Koetting, and we're going to be talking about not getting crossed in today's OI show. Cecelia, thanks for being on the show today. Appreciate it. If you could give the audience just a little bit of a background on yourself, where you practiced, where you went to school, when you graduated.
Yeah. So I went to Southern College of Optometry in Memphis and graduated about 2012. I went on to do my residency at Cincinnati VA, and then practiced a little in Arizona and came to Virginia to practice with Virginia Eye Consultants about 8 years ago. And we are a secondary tertiary referral medical center. So I work with a fairly large group of MDs and ODs, seeing quite a bit of really interesting patients.
Yeah, you work with arguably some of the best in the profession, both in ophthalmology and optometry, Cecilia. I know that you have a rich lineage within eye care. Your grandfather, Dr. Robert Koetting, was a pioneer when it came to contact lenses. And much of what we know with contact lenses, in particular with some of the specialty lenses and fitting some of our more advanced patients, come from the foundation that your grandfather actually laid. What's interesting is he was a pioneer at the time, and you fast forward to today, and I see a lot of that in you. We had the opportunity to share some of the stories at AOA, but you guys are doing a lot of advanced things, and one of the things that you're really becoming entrenched in is keratoconus, but not necessarily the correction optically of keratoconus, but managing it, and describe that a little bit more to us, the audience, and how that's like fundamentally changed over the last decade.
Yeah, so it's been really interesting to be a part of and being in a practice that has the benefit of a lot of really advanced technology, as well as some of the, like you said, arguably best minds in both MD and ODs. We have great ability to diagnose these patients earlier, even within the last, 5 years, not even a decade, with the advent and implementation of the Pentacam with the Schleimflug. So I, even within the last year, we've had the Pentacam, but hadn't really been utilizing it to its full potential when it comes to our keratoconus patients in helping to identify them earlier and watching for changes. So I've really kind of jumped on board with that over the last year, getting a better working understanding of
Yeah.
the technology itself. And then we also have been doing crosslinking for a number of years. We were part of some of the studies for the approval by FDA for the United States. And then we've also continued past that to treat our patients with it. So with the ability to identify earlier and then also treat in-house for those patients to really stabilize them prior to getting to the point when they have more corneal damage and scarring and decrease in vision to where we need to do a transplant. I think that's really been super interesting and a definite game changer for our patients.
Well, that's where I think it's all changed, because I remember, like, even when I was in school, we learned about keratoconic patients, how to refractively correct them as best as possible, whether that entailed glasses, soft or rigid gas permeable lenses. And then we would talk about essentially waiting, and if they got bad enough, they would require a corneal transplant. But this is a totally different mindset. This is a totally different shift. Describe to the viewers why it's so important to catch these patients early on to help prevent.
So describing to you all, it's so important to identify these early. And you're absolutely right. It was I'm sorry you have keratoconus. We're going to make you see okay, or the best we can, until you potentially need a transplant. And the problem with transplants is that, they have a life. They aren't going to live forever. They aren't going to work forever. Typically, the average corneal transplant, that's not a hard and fast rule, but is about 20 years. And then they need to have it done. Our keratoconic patients are starting with problems in the late teens, early 20s. And so we're talking about somebody who's in the early decades of their life. and we know are going to live longer than 20 years. Therefore, they're going to have repeat transplants, which can be costly. It is difficult for them. It is a very time-consuming, involved thing, just not only for the surgery itself, but also for the care and the maintenance on the patient side for the rest of their life. Yeah. It also means issues with even just optical clarity with the corneal transplant, even though most of the times it is better than their previous keratoconic eye. Now, if we can identify these patients earlier and get them treated earlier, this can make a huge difference in somebody's life. One, not just for the transplant, but two, if we do cross-linking as they're younger and identifying it before they have such a high amount of astigmatism that they have overall poor optical clarity, even with glasses or contact lenses, we can potentially improve their quality of life and allow them to have more options as far as, even what they'll do with their life, because they have a much more stable eye and a much better clarity as far as optical vision.
Yeah, some of these patients, like we might even, if we catch them early enough, we could arm them with a life of glasses as opposed to even needing to go to contacts or specialty contact lenses.
Yeah.
And even if they require specialty lenses, oftentimes when the ectasia gets so severe, it becomes much more difficult from a fitting perspective. So all of those things just make it easier for the patient, better quality of life, like you said, and it makes the whole process easier for them to manage because now they have functional glasses if they need them. Now they have the functionality of contact lenses if they need it. There's another component here too, Cecelia, and I think, catching and identifying these patients early, we communicate with them differently, right? Reducing their environmental risk factors. Tell me how that conversation looks like in your office. If you're identifying somebody who either has questionable results on topography or tomography, or you've clearly identified it, but it's at a very early phase. I mean, what's the conversation start, or what does the conversation look like from there?
So when we're at that early stage and we're identifying it, there is absolutely environmental. So we talk more about making sure, obviously, if we have underlying allergies, we're treating that, decreasing any eye rubbing, anything that could be of risk that we know puts them at a higher risk to progress. But I also am talking with them about having cross-linking early and as early as we possibly can. If I can identify that it's very early keratoconus, you're absolutely having it. If there's a risk that somebody has it, and I think that I'm suspicious of it, we do have the genetic testing now that even though it's not giving, it's not specific and saying yes or no, they don't have it. It gives us a percentage of likelihood that they'll develop it.
So Cecelia, just to be clear here, so if you're kind of finding some suspicious findings on tomography where it's maybe not necessarily a clear-cut cone, but you're saying there's some risk factors here that make me suspicious, you're then ordering the genetic test, correct? Yeah. And is that how's that administered in the office?
So we do the swab in office and send it out. It's a fairly easy process. We do have our staff trained to do it. So I don't do it myself, but we do have the staff help us with that. And then we're able to send that out and gain some more information that might weigh, a little bit more heavy in helping us decide how closely we are going to watch the patient, or do we want to go ahead and preemptively, they're 90% likely that they're going to develop it. Do we want to go ahead and treat with cross-linking at that point? It also is a good thing. And one of our surgeons is very on board with using the genetic testing anytime she has a patient that is going to be doing PRK or LASIK. And is she even slightly is suspicious or there's a family history of keratoconus, she'll go ahead and administer that just so that we're not putting a patient at risk for developing keratoconus or ectasia or higher risk of ectasia further down the line after the surgery.
That's remarkable. With the diagnostic tools that we have, we're able to catch things sooner. And never did I think that we would be able to assess genetic risk and make that come into play. I really see, like, every disease state that we manage, glaucoma was really the one where we first just kind of started catching subtleties in terms of nerve fiber layer defect, ganglion cell complex reduction. That's those structural changes that you just can't see anyplace else. And it's kind of spread to everything that we do in optometry. We're just getting better at catching conditions earlier because we know the sooner we catch it, the sooner we can start discussing the reduction of environmental risk and also, too, putting those patients on an appropriate path of treatment. I think corneal crosslinking, again, it just provides this facet, this avenue for keratoconic patients that never existed before. So now they have this likelihood of significant slowing down of progression, if not complete slowing down of progression by resolidifying the collagen in the cornea. And I just think it's a beautiful option for these patients and helps prevent some of these more severe cases from occurring. So in your experience, Cecelia, what is the, like when is a patient not a candidate for corneal cross-linking? Like when is the keratoconus so severe that they really can't do it?
Yeah, so there are a couple of different things that can move them out of being having that as an option. Typically, I mean, a definite one is somebody who has keratoconus to the point where they're having corneal scarring and significant striae, where we know that this patient is just really past that even if it stabilizes it, the visual potential is just not going to be great, and they would benefit more from having a transplant. Patients who have a strong history or a history of any kind of herpetic keratitis, stromal, epithelial, anything where we know because we're using UV that it's potentially going to cause it to activate. And then patients who have thin pachymetries where their apex has become so thin, I believe it's 450. And that again is not, there's a little nuances with that. I know that when we use some of the drops for the cross-linking, it actually causes swelling of the cornea, so that we're able to treat some people who, when we do natural pachymetry prior to, are a little bit under that 450, 400 micron level, because we know during the process, it will actually thicken and protect the cornea while we're doing it, so that they're not running a risk for further problems.
So reiterating what you said initially, it's best to get these patients treated sooner to prevent them to the point where they may not necessarily be able to get treatment.
Yeah.
So Cecelia, thank you so much. We're just about out of time here. I could talk another hour with you. We'll definitely have you back. And thank you all for joining us on the OI Show. Make sure you subscribe to our podcast. And Cecelia, once again, thank you for being on the show.
Absolutely. Thank you for having me. This was great.